PARP is a interesting enzyme. It's part of the process what we call of DNA repair called base excision repair. It was discovered in 2005 that in cell lines that had lacked BRCA, so these were BRCA homozygous knockouts, that when you gave those cells a PARP inhibitor, that they had about a 1,000-fold sensitivity for their cytotoxicity for when they were administered. So this was an experiment done in the dish where they took these cells. If they had the machinery, which we call homologous recombination, if that was intact, those cells did fine until there was given very, very high doses of a PARP inhibitor. But when they lacked it, there was about a 1,000-fold increase in sensitivity. And that was strong proof that this damaged HRD, what we call the homologous recombination deficiency, that the damage of that process made these cells extremely vulnerable to PARP. So then we started thinking about, well, how does that happen? Well, as it turns out, when you inhibit a base excision repair process, over time the cells, under the cellular stress of division, those cells actually are more prone to develop double-strand breaks. And there are a few ways that the cell can actually repair a double-strand DNA break. The one that has the highest fidelity and the most often used is the one that's governed by the BRCA genes. So BRCA 1 and 2 act in concert with other genes to actually initiate this repair of a double-strand DNA break. And there's some other repair processes that are also included, but this is the one that has the highest fidelity and has the most opportunity for cell survival. So as a normal cell, or in a normal situation, if BRCA is intact, then this double-strand DNA break, which is induced by a PARP blockade, actually can be repaired fine. But if the cell is damaged, doesn't have that machinery intact, the cell will die. So neither one of those events is lethal, meaning lack of BRCA or use of a PARP inhibitor. But if you combine them, you get what's called synthetic lethality. We started to look at a broader audience. So we knew about the germline, but we knew that there were patients where the tumors actually had the mutation, but the germline was negative. So they were wild type for BRCA in the germline, but the tumors actually had BRCA mutated. And we found that 7% or so of patients were also sensitive to the compound, the PARP inhibitors. And this was shown in one of the drugs which is recently approved called rucaparib, which did a large phase 2 trial called Ariel 2, which showed that patients who had both germline and somatic mutations actually had a response, and the same degree of response that we would see in the patients who had it in the germline. So we also started to look at this in patients who had multiple lines of prior therapy, and the drug olaparib, which is now approved for fourth line and beyond as treatment for germline BRCA mutation, showed that these patients who have had multiple lines of prior therapy were still responding. And it wasn't that they were just responding, they were responding at a rate that was substantially higher than what was expected by chemotherapy. And I think that was what was influential in the FDA opining on the decision to grant accelerated approval to olaparib in patients who had had 4 or more lines of therapy if they had carried a germline mutation. And actually the response rate in that trial, called the Kaufman report, showed about a 34% response, which was impressive. But what even more impressive is that the 95% confidence interval around that 34% goes down to right around 25%. And if you look at what the expectation is for chemotherapy in the same lines of patients, it's more than 4 standard deviations away. So while the number doesn't seem very high, and that lower limit of confidence doesn't seem very high, it is so much better than what is expected from chemotherapy in a general population that it was persuasive, and I think it was rightfully done. So those 2 drugs, rucaparib and olaparib, were approved in patients who have specific characteristics. In other words, olaparib being germline, rucaparib being germline and somatic mutation for BRCA. So that was also interesting, but in the background we were also doing trials in patients that were wild type. Now, in some of these trials, we didn't know that they were necessarily somatic mutations or not, but we started to see patients who were wild type for BRCA in the germline having responses. So it launched kind of 2 different investigative angles. One was to look for the somatic mutations, which, as I mentioned, happens in about 7% of patients. But we started to look at the other genes that are responsible for homologous recombination, that central component that drives the the repair of double-strand DNA breaks. And we found that there may be as many as 30 genes that are responsible for that. Now, what's interesting is that not all of those genes are have the same sensitivity to a PARP inhibitor. In fact, some of these genes have absolutely no sensitivity to a PARP inhibitor, even though they're responsible for that DNA repair process. So that was kind of an interesting observation that has now started to come forward. But what it told us was that there are patients in the general population that are not identifiable by the germline testing or the somatic testing who respond to PARP inhibitors. Well, that was a big win, because what it told us was that maybe we could expand this to a broader audience. And so one of those audiences that we felt what might be a good way to do this was to look at patients who had responded to a platinum-based drug. As we've known for many years, patients that are platinum, that have BRCA mutations, actually show exquisite sensitivity to platinum. And I think, as I mentioned in my previous comments, that the adducts that are formed because of the platinum cause a double-strand break at a higher rate. So these patients you would expect to have a higher degree of potential sensitivity. So these trials, which banked on that particular physical characteristics of response to platinum, said, hey, what do we do when we finish that treatment and then randomize those patients to a PARP inhibitor because they've responded to platinum or placebo and see how well they do? And that bore the concept of switch maintenance.